Podcasting from beautiful Sydney, the city of Opera House, Darling Harbour, Blue Mountains, and beautiful beaches. This is ICU Primary Prepcast, a monthly podcast about physiology and pharmacology in intensive care.
Hi, I'm Maddi.
Hi, I'm Swapnil. And today we are going to talk about thyroid and parathyroid physiology in our episode number 2 of Endocrine Physiology. Thyroid can be a commonly asked question in exams. So can you please describe the secretions and functions of the thyroid?
Sure. So the thyroid is a highly vascularized butterfly-shaped gland located anterior to the trachea and consists of 2 lobes connected by a thyroid isthmus. The follicle is a functional unit of the thyroid. Each follicle is filled with colloid, which is mainly thyroglobulin, and surrounded by a single layer of cuboidal cells. The thyroid gland produces 2 thyroid hormones, triiodothyronine or T3 and thyroxine or T4, as well as calcitonin, a hormone involved in calcium homeostasis. We will discuss calcitonin a bit later when speaking about the control of calcium. Firstly, let's focus on T3 and T4 and outline their formation, transport, functions, and regulation. In terms of their formation, iodine is essential for the formation of both T3 and T4, with a minimal daily requirement of 120 to 150 micrograms. Iodide is transported from the blood into thyroid follicles through a secondary active transport system of sodium iodine cotransporters and sodium potassium ATPase at the basolateral membrane. This is termed iodide trapping, and the concentration within these cells can rise to up to 250 times that of blood concentration. Iodide is transported to the apical membrane and into the follicular lumen by an iodine chloride exchanger called pendrin, where it is then oxidized to iodine through the action of thyroid peroxidase and hydrogen peroxide. Meanwhile, the endoplasmic reticulum and Golgi apparatus within the thyroid cells secrete thyroglobulin, which is a large glycoprotein molecule containing multiple tyrosine residues. The thyroglobulin combines with iodine, and the tyrosine is first iodized to monoiodotyrosine, then diiodotyrosine, which is then coupled to form T4. Alternatively, the monoiodotyrosine combines with diiodotyrosine to form T3. Some of the monoiodotyrosine and diiodotyrosine do not undergo coupling, but are rather deiodinated by a deiodinase enzyme, with the iodine released being recycled for further hormone synthesis. The process of thyroglobulins combining with iodine is termed organification, and it occurs very rapidly in the thyroid due to the presence of iodinase within the thyroid cells. T4 makes up over 90% of the hormone formed by the thyroid. However, T3 is about 4 times as potent as T4.
Okay, so that's about the formation of the thyroid hormones. Now, can you tell us how these hormones are transported or circulated in the body?
So T3 and T4 are cleaved from the thyroglobulin molecule via the action of lysosomal enzymes and are subsequently released into the blood. The thyroid hormones are lipophilic, and over 99% of thyroid hormones are carried in the blood, bound to plasma proteins, mainly thyroxine-binding globulin, but also to prealbumin and albumin. T3 has a lower affinity to plasma proteins compared to T4, therefore approximately 0.2% of T3 exists in unbound form compared to 0.02% of T4. It is the unbound or free form of thyroid hormones that is biologically active. T3 has a shorter half-life of 1 day compared to that of T4, which has a half-life of 6 days, and T3 has a faster onset of action. The majority of T4 is deiodinated in the tissues to T3 or to reverse T3, which is biologically inactive.
That's correct. The T3 has got a short onset of action and it lasts for a shorter period of time in the body. So if you're treating someone with a myxedema coma, you have to give IV levothyroxine which is IV T3. While if you're treating somebody's chronic hypothyroidism, you usually administer thyroxine, which is T4, but which usually takes time to improve the thyroid levels. Now, what are the different functions of thyroid hormones?
So thyroid hormones combine with receptors to alter the expression of certain genes which code for proteins that regulate cellular function. The thyroid hormone receptors have a much higher affinity to T3 compared to T4. The overall effect of thyroid hormones is to increase the metabolic activity of nearly all tissues within the body. We can briefly outline these effects by system. In terms of central nervous system effects, thyroid hormone increases the rapidity of cerebration and promotes normal cerebral development in the fetus and in infants. In terms of the cardiovascular system, thyroid hormone results in increased inotropy and chronotropy by an increased number of beta-adrenergic receptors and increased response to catecholamines. It also results in vasodilatation and increased tissue blood flow. In terms of the endocrine system, thyroid hormone increases fat metabolism and lipolysis and increases the basal metabolic rate. It also stimulates carbohydrate metabolism and causes increased glycolysis, gluconeogenesis, and increased insulin secretion. It also decreases the circulating levels of cholesterol. In terms of the respiratory system, thyroid hormones result in an increased respiratory rate. Gastrointestinal tract effects include increased gastric motility, increased appetite, and increased secretion of digestive juices, as well as increased absorption of glucose. Musculoskeletal effects include protein catabolism, which is increased, and increased protein synthesis. It also promotes the normal growth and skeletal development. And finally, reproductive effects include a requirement for normal spermatogenesis. It's also required for follicle development and ovulation, and is required for the maintenance of pregnancy.
Thanks. And can you please describe the regulation of thyroid hormones?
So thyroid hormones are regulated by a closed-loop negative feedback system. This is controlled mainly by circulating levels of thyroid-stimulating hormone, which is a hormone secreted by the anterior pituitary gland. Thyroid-stimulating hormone secretion increases in the presence of thyrotropin-releasing hormone, or TRH, which is secreted by the medial eminence of the hypothalamus and transported to the anterior pituitary. Secretion of TRH and therefore TSH increases with the cold and is inhibited by high levels of T3 or T4, also by glucocorticoids and dopamine. TSH is mainly inhibited by increased levels of free T3 and T4, but can also be inhibited by anxiety, increased sympathetic nervous system stimulation, somatostatin, and warm weather. TSH acts by the second messenger cyclic AMP system to cause several effects. It increases the proteolysis of thyroglobulin, resulting in the release of thyroid hormone into the blood. It increases the activity of the iodide pump. It increases the iodination of tyrosine, and it increases the number, size, and secretory activity of the thyroid cells. It therefore works in numerous ways to increase the production and release of thyroid hormones. Increased levels of circulating thyroid hormones also causes a large proportion of T4 to be converted peripherally to the inactive reverse T3 instead of T3. Several conditions can also suppress certain deiodinases, resulting in low T3 levels and increased reverse T3. These include burns, trauma, cirrhosis, renal failure, and infections, all of which are commonly seen within the ICU.
That's correct. And I think that's why it's very important for ICU trainees to understand how to interpret thyroid function tests, because a lot of ICU patients or critically ill patients will have this, what you call it as a sick euthyroid profile, where basically you will have borderline or slightly decreased T3, T4 levels and increased TSH levels, but they're not classified as a hypothyroid and they don't need any treatment. And then in terms of diagnosing the hypothyroidism or hyperthyroidism, always remember that the T3, T4 levels go in opposite direction to the TSH. In hypothyroid patient, the TSH will be always elevated versus hyperthyroid patients, the TSH will be always decreased. Now, moving on to another gland, which is the parathyroid gland. And the main function of this gland is to control the calcium levels in the body. So can you please tell us the control of plasma calcium in the body?
So, careful control of calcium levels is essential due to calcium's crucial role in many physiological processes, including nerve conduction, muscle contraction, including cardiac, coagulation, bone structure, hormone release, and cellular metabolism. The adult human body contains about 25 mole of calcium, the majority of which, or 99% of the body, is in the bone, whilst about 0.9% is in the intracellular fluid and 0.1% is in the extracellular fluid. The 0.1% of calcium within the extracellular fluid has a plasma concentration of about 2.2 to 2.6 millimoles per litre and can exist in three main forms. The first, or 40% of which, is combined with plasma proteins such as albumin. This calcium is not diffusible through the membranes. The second form, or 10%, is combined with anionic substances such as citrate, bicarbonate, and phosphate, which is diffusible through membranes but unionized. And the final, or 50% of which, is diffusible ionized or free calcium. It is this unbound or ionized calcium which is biologically active and thus tightly regulated. The approximate daily intake of calcium is 1,000 milligrams, of which about 30 to 40% is absorbed from the intestine. The remainder is excreted in feces, along with about 250 milligrams per day of calcium that is secreted into the gastrointestinal tract. About 10% or 100 milligrams of the daily calcium intake is excreted in the urine, with the majority, or almost 99% of this filtered calcium, being reabsorbed by the kidneys. Bone also provides a reservoir of calcium, with calcium stores existing in bone in two main types. The first type is a readily exchangeable reservoir, which provides a rapid buffering mechanism to help maintain appropriate plasma calcium concentrations. And the second type is a much, much larger stable group of calcium that consists of over 99% of bone. The first, or exchangeable portion, accounts for about 500 millimoles per day of calcium movement to and from the bones. Calcium levels in the plasma are controlled by two main hormones, vitamin D, or 1,25-dihydroxycholecalciferol, and parathyroid hormone. To some extent, calcium levels are also controlled by a third hormone produced by the thyroid called calcitonin. Both the gastrointestinal and renal absorption of calcium is promoted by vitamin D. Vitamin D3, or cholecalciferol, is formed in the skin by UV light and is converted to 25-hydroxycholecalciferol in the liver. This is then converted to 1,25-dihydroxycholecalciferol, or calcitriol, in the proximal tubule of the kidney by the action of renal 1-alpha hydroxylase. 1,25-dihydroxycholecalciferol promotes the intestinal absorption of calcium by increasing transient receptor potential vanilloid type 6 molecules, which transport calcium from the intestinal lumen into the cell, increasing calbindin D proteins, which bind calcium within the cell, and also by increasing the number of calcium ATPase molecules, which transport calcium from the cell into the bloodstream. It also increases intestinal absorption of phosphate. 1,25-dihydroxycholecalciferol also increases calcium reabsorption in the kidneys via increased transient receptor potential vanilloid type 5 molecules within the proximal tubule, and also increases the synthetic activity of osteoblasts. As plasma calcium levels increase, the levels of 1,25-dihydroxycholecalciferol fall, with the kidney producing the relatively inactive 24-25-hydroxycholecalciferol instead. Low calcium or phosphate levels and increased parathyroid hormone levels causes increased 1-alpha-hydroxylase and thus increased 1,25-dihydroxycholecalciferol levels, thereby increasing calcium levels. The second hormone is parathyroid hormone, which is a polypeptide hormone produced by the parathyroid glands. Parathyroid hormone acts on the kidneys to increase reabsorption of calcium in the distal tubules via TRPV5. It also increases the formation of 1,25-dihydroxycholecalciferol, thereby increasing the reabsorption of calcium from the intestine, and it increases bone reabsorption, both immediately through the activation of osteocytes and more slowly by the proliferation of osteoclasts. PTH reduces urinary reabsorption of phosphate but increases intestinal absorption of phosphate. PTH levels are very sensitive to changes in calcium ion concentration. Decreased calcium levels causes increased parathyroid hormone levels and vice versa. Increased plasma phosphate levels also stimulate parathyroid hormone secretion. Importantly, magnesium is required for normal parathyroid hormone response, and severe hypomagnesemia can suppress PTH secretion, resulting in hypocalcemia. The final hormone is calcitonin, which is produced by parafollicular cells in the thyroid gland and acts to lower serum calcium and phosphate by inhibiting bone resorption and increasing calcium excretion in the urine. Its production is mainly stimulated by increased plasma calcium levels, but it is also stimulated by hormones including estrogen, gastrin, glucagon, and dopamine. However, the importance of calcitonin in calcium homeostasis is unclear, as patients post-thyroidectomy have negligible changes in their calcium levels if their parathyroid glands are left intact. Several other hormones have some effect on calcium homeostasis, including glucocorticoids, which lower calcium levels due to inhibition of osteoclasts and decreasing intestinal absorption of calcium, and growth hormone, which increases intestinal calcium absorption but also increases urinary calcium excretion.
Thanks, Maddi. Now, as you mentioned, the kidneys play important role in calcium regulation. However, kidneys do have some other endocrine functions apart from calcium regulation. Can you please describe the various endocrine functions of kidney?
Sure. So the main endocrine functions of the kidney are the production of renin, erythropoietin, and calcitriol. So renin is a protease secreted in the juxtaglomerular cells within the kidney. It's synthesized as a pre-pro hormone, preprorenin, which is then cleaved to the biologically inactive prorenin, which is then converted to renin within the kidneys. Renin is important as it catalyzes the conversion of angiotensinogen produced in the liver to angiotensin 1. Angiotensin 1 is then converted by angiotensin-converting enzyme to angiotensin 2, which has numerous effects, including arteriolar vasoconstriction, increased aldosterone secretion, sympathetic stimulation, increased renal sodium reabsorption, increased ADH and ACTH secretion, and attenuation of the Barrow reflex. Renin is stimulated by decreased afferent arteriolar pressure sensed by intrarenal baroreceptors, also by decreased sodium chloride delivery to the distal tubules, which is sensed by the macula densa, and by increased catecholamines or sympathetic activity and decreased angiotensin 2 and decreased ADH levels. The second hormone is erythropoietin, which is a glycoprotein hormone formed mainly in the peritubular capillary bed in the kidney, but also about 10% of it is formed in the liver. Erythropoietin increases the production of pro-erythroblasts from hematopoietic stem cells within the bone marrow, and it also increases the speed with which these cells mature. Erythropoietin is stimulated by hypoxia, hypotension, low hematocrit, and by catecholamines. We've already discussed 1,25-dihydroxycholecalciferol or calcitriol, which is the final activated form of vitamin D and takes place within the kidney. The kidney also has some other very minor endocrine functions. The proximal convoluted tubule of the kidney can produce a very small amount of thrombopoietin. The majority of thrombopoietin is produced by the liver. Thrombopoietin is a glycoprotein responsible for influencing stem cells to develop into megakaryocytes and thus produce platelets. The kidneys also have some ability, like the liver, to carry out gluconeogenesis.
Thanks, Maddi. And I think now we are heading into that most unpleasant part of the podcast where you're going to ask me some question.
It's my favorite part of the podcast.
That's correct. It's all about perception. So go for it.
Okay. So what type of car do endocrinologists most like to drive?
Look, I'm not sure about the endocrinologist, but I like to drive Ferrari, okay? To be honest, I don't know the answer.
A Gland Rover.
Maddi, I'm really curious to know, where do you come up with all these jokes?
I don't know, just a good sense of humor, I guess.
That's correct. Anyways, I think people are enjoying your jokes. That's what the feedback I got so far. So thanks, folks. Thanks for listening. ICU Primary Prepcast. Now, if you liked today's episode, we hope that you will pass along our web address, that is www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Now, also make sure that you check out our archive section on our websites for previous episodes, including the episode on endocrine pharmacology. All the show notes related to this episode will be available on the website. So make sure that you access the show notes and check the diagrams relevant to today's episode. You can also follow us on Facebook at Critical Care Education. And don't forget to join us next time for another episode of ICU Primary Prepcast. Till then, goodbye and have a nice time.
Thanks for listening. See you next time.